Hi, everyone. It's great to get the chance to talk with you all about the approach to sexually transmitted infections. I'm one of the second-year residents, and I'm in the HIV medicine pathway. And I am um, happy to be part of the academic half day for today, and also getting this month teaching alongside Sarah and all the other educators that I got to work with. I don't have any conflicts of interest. I'm also learning more about this topic and continuing really to learn more. And I wanted to thank Drs. Budak, Lamont, Thronson, Dr. Tong, all for their guidance on this presentation. I'm using CDC's STI treatment guidelines from 2021 as a reference. So the goals of the talk today, first is to provide a foundation for prevention, screening, and treatment of common STIs in clinic. And I also hope to explore diagnostic and treatment approaches for two common STI syndromes, urethritis and vaginitis. The objectives of the talk: discussing screening for gonorrhea, chlamydia, trichomonas, HIV, and syphilis, discuss treatment for gonorrhea, chlamydia, and trichomonas, list differential diagnoses of urethritis and vaginitis, discuss vaccination schedules for preventable STIs, and then recognizing HIV PrEP and providing a list of King County STI testing sites. So the mental framework that I wanted to approach the topic of sexually transmitted infections with is, on this flow diagram here. It all starts with a thorough sexual history that's conducted and interviewed in a non-judgmental manner, and that's really the foundation for the whole, the whole visit. The next part is STI prevention. After discussing STI prevention, it's also important to know about asymptomatic screening, as well as if patients have symptoms like diagnosing and treatment of STI syndromes. We're going to touch upon urethritis and vaginitis today. So the areas in blue are the topics that I hope to cover. And then the areas in gray are potential for future learning. And we won't be able to finish all the STI syndromes that are available for discussion, but on our separate learning can consider talking about PID and proctocolitis and ulcers and lesions. So I just wanted to start off, with the case. We have Betty. She's a healthy 28-year-old woman establishing care in clinic today. She feels well, she has no symptoms. Her sexual history: she has 3 male partners in the last 3 months. She sometimes uses condoms, has receptive vaginal intercourse and receptive oral intercourse. Her partners have also other partners, and she uses a Nexplanon for contraception. And just opening it to the group, if someone wants to say it out loud or on the group chat, which STI screening tests would you recommend for Betty today? Great. I'm seeing on the chat that Nikki and Tony have recommended gonorrhea, chlamydia, trichomonas, HIV, syphilis, and then specifically gonorrhea and chlamydia, vaginal and oral swabs, HIV, and an RPR screening. Awesome. So I wanted to bring attention to the in terms of sexually transmitted infections, there are so many pathogens that we've been taught in medical school. And I just wanted to talk about the ones that are the most prevalent here in our clinical practice, and then dividing them up into buckets of what kind of pathogens they are. And the goal of the talk today isn't really about the microbiology of these pathogens, nor is it about like the pharmacology of what to treat them or like how the medicines work. It really is to really develop a framework for how to approach clinical cases. So one framework that I like to think about is dividing these pathogens up into what buckets they belong to. So talking about viruses, HIV, herpes simplex, human papillomavirus, MPox, or previously known as monkeypox, and then also be concerned for viral hepatitis A, B, and C. While viral hepatitis isn't considered usually a sexually transmitted infection, Heps A and B and C can all be transmitted sexually. In terms of bacterial pathogens, syphilis, chlamydia, and gonorrhea are things that we want to be keeping in mind of, and then Trichomonas, which is a protozoan. And then talking a little bit about epidemiological trends in King County, we have this diagram here, and it's data for women and men who have sex with women in King County. The top panel is for gonorrhea, and the bottom panel is for syphilis. So paying attention first to the top panel, we see that for gonorrhea overall since 2020 to quarter three, so 2022 quarter three, the trends of gonorrhea has really remained stable throughout. However, in terms of syphilis, we're seeing an uptake, and this uptake we're seeing in both the cisgender women population, men who have sex with women, as well as the pregnant women population. And this is a gradual uptake in the cases since 2020 that we see. And then the next set of diagrams is for men who have sex with men. And the top panel is for gonorrhea. We see in the trends an uptake in 2021 of new gonorrhea cases, however, then since plateauing since 2022. And then for syphilis, we're also seeing that the total cases of early syphilis has gradually risen from 2020 to 2022. And we're seeing an increase in these STIs, and that's why I wanted to talk about the importance of STI screening with our group today. Chlamydia data isn't well represented here because it's per the King County website. Chlamydia data has had some intersparseness, and they weren't able to collate data. So I just now wanted to propose a screening paradigm for the group to approach asymptomatic screening for our patients. And we're going to break it up into 3 parts. This is a relatively more busy slide. And regarding the first group, tests that we should obtain whenever a patient has symptoms, or if a patient has a new partner, or every 3 months if a patient has multiple partners. So as the group had already pointed out, we wanted to screen for gonorrhea, chlamydia, syphilis, trichomonas, and HIV. I'm going to talk about each in a little bit more detail, starting first with gonorrhea and chlamydia. So gonorrhea and chlamydia is usually screened with a nucleic acid amplification test. And in clinic, we want to counsel the patients that we want to screen each body part that a patient has sex with. And terminology like, I just want to be mindful of how inclusive our terminology is and how to use inclusive terminology in clinic. And what I'm trying to say is that some patients might not identify their body parts as penis and vagina, and those are very binary terms. So oftentimes, like giving the option to just say screen each body part that a person has sex with. With that said, oftentimes for a thorough evaluation, depending on the patient, you want to consider a throat swab, a rectal swab, and then either a urine or a vaginal swab. For men, a first catch urine would be a sufficient sample. And for women, vaginal swabs are superior over first catch urine samples. In terms of patient-collected samples, those are preferred over provider-collected samples, especially for the comfort of the patient, for privacy, and the yield is actually better too. And then just wanted to talk a little bit about for women who have receptive vaginal intercourse, but not receptive rectal intercourse. CDC has really liberalized the screening terminology and language behind that. So at this point, our practice in Madison Clinic has also been to counsel the patient about rectal screening and talking to the patient that, like, well, during sex, like things can get a little bit messy down there, and it might be, highest yield to also get a rectal swab along with the vaginal swab. Yeah. Before we go on, I see that there is a question in the chat box. It says, Jordan said, interesting to see the data broken down by the site of infection. Oh, got it. Yes. And then that's the discussion about gonorrhea and chlamydia nucleic acid amplification test screening. Any questions before we continue? Okay, so the next part is for syphilis screening. And you would obtain a serological syphilis screen if a patient never has known syphilis, and an RPR if a patient has history of syphilis. For Trichomonas, it's also a nucleic acid amplification test, or NAAT. And this is recommended if a patient has receptive vaginal intercourse. And then an HIV antigen antibody testing. The second bundle of tests to obtain is for when a patient first establishes care in your clinic, and obtaining tests for hepatitis A, B, and C. So starting first with hepatitis A, getting a baseline immune status, whether a patient has immunity, would be helpful if a patient is in the following populations: if they're men who have sex with men, or if they have international travel, insecure housing, or IV drug use. For hepatitis B, we want to obtain screening for men who have sex with men, or anyone who has more than one sex partner in the last 6 months, if they're coming in for an evaluation of an STI, or if they have past or current injection drug use, or if they have a partner who has a positive surface antigen for hepatitis B. So those are all risk factors that confer risk of Hep B and would be benefit from screening. And then lastly, for Hep C, the screening test is a Hep C antibody with reflex PCR. And all adults once in a lifetime should receive a hepatitis C screen. And then for men who have sex with men and people with injection drug use, then every 1 year as well. And lastly, screening for herpes simplex and MPox depends if a patient has lesions. And if they do have lesions, then you want to get a swab directly at the lesion. And then just wanted to see the question. Nikki asked, what is the rate of asymptomatic rectal STIs in people who do not have a positive vaginal swab? That's always been one of my hesitations, since the rectal swab feels more invasive for many of my patients. That's a really good question, and I don't have the answer. Oh, I see that Caitlin had put in an answer. From the research, it's uncommon to have a positive rectal swab and a negative vaginal swab in women who don't report anal sex. But if I recall accurately, one study suggested that we may miss up to 2% of infections in these patients. Thank you, Caitlin. I think that's really great for me to learn. All right. So now going back to our case for Betty in our first case, given that she has sex with her vagina as well as with her throat, we want to obtain 3 swabs, the rectum and vagina, and then also obtain a syphilis screen, Trichomonas test, and an HIV antigen antibody. And in regards to her establishing care today, given that she has multiple partners, want to get a hepatitis B battery today, get the lifetime screening for hepatitis C, and then discuss with her for shared decision-making about Hep A testing, whether she has any international travels, whether there's any housing insecurity that might impact her decision, and substance use history. And then lastly, since she doesn't have any symptoms today, we won't need the HSV or MPox screening. Any questions about this? Okay. All right, so we're going to move on to case 2. So we have Casey. He's a healthy 30-year-old man who has 3 days of urethral discharge and pain on urination. For his sexual history, he's had 4 partners in the last 6 months. And with men, he has oral insertive and receptive intercourse, anal insertive and receptive intercourse. With women, he has oral insertive and vaginal insertive intercourse. And he uses some condoms sometimes. He has a history of gonorrhea in the urethra in the past. So I just wanted to kind of gauge the room and ask a polling question about when Casey should be initiated on treatment. Would you, in your current practice, provide STI treatment today and defer STI testing, or provide both STI testing and treatment today, or provide treatment after the STI testing results come back? Sarah, whenever it's a good quorum, feel free to close the poll. And okay.
Votes are still rolling in. About 48% have participated. And watch out, guys, the generic poll has an option D. Doesn't not have an option D. That's okay. All right.
Awesome. So it looks like 70% of the patients would like to have STI testing and treatment today. Sorry, my pager is going off. Let me mute. Okay, that was very loud, but hopefully you all don't have headphones on. So B is the correct answer. We want to prioritize same-day testing and treatment in clinic, and this is good for a public health point of view. And also because sometimes, especially for patients who have difficulty making it to appointments, we want to give them the treatment earlier rather than later. All right, B is the correct answer. So continuing on this case, Casey has no prior testing records in the EMR. Which diagnostic tests would you recommend for him today? And then what organisms would you want to treat empirically for? And feel free to type on the chat box while I go silence my picture. All right. Thank you, Tony. So screening for hepatitis A, B, and C, and RPR and HIV testing. And then for Gina, treating for gonorrhea, chlamydia, testing for all those mentioned prior plus hepatitis. So you both are correct. So this is the diagnostic test and empiric treatment that we want to recommend today. 3-point gonorrhea and chlamydia testing, syphilis screen, HIV antigen antibody, and then Hep A and B and C screening, and then provide empiric treatment for gonorrhea and chlamydia. So now just talking a little bit about gonorrhea treatment. It's ceftriaxone 500 milligrams intramuscular once. If a patient weighs greater than 150 kilos, then give a 1 gram intramuscular dose. Generally, it's well tolerated without any side effects. We've all probably given ceftriaxone in the inpatient setting for UTIs, for community-acquired pneumonia. People do well on it. There's really not many side effects. And for test of cure, it's specifically recommended in the CDC STI guidelines for pharyngeal gonorrhea, and starting 14 days after ceftriaxone treatment. And with that said, the recommendation isn't, I feel like, practiced as consistently in the real world setting due to more of a limited evidence base behind it. However, the official recommendation is to also get a test of cure for pharyngeal gonorrhea, given that the ceftriaxone might not penetrate into the throat tissues. And it's a theoretical concern, so it is still a recommendation. For chlamydia, the treatment is doxycycline 100 milligrams twice daily for 7 days. Oftentimes, I would counsel a patient about side effects, including photosensitivity, esophageal irritation, GI distress. And photosensitivity in Seattle in the winter isn't really a big issue, but in the summer, when we do get a lot of sun, and I would ask patients to consider wearing a sunscreen if they're taking doxycycline. And then esophageal irritation, asking patients to take the medication while upright, not in bed, take it with a glass of water. And GI distress, counseling on some just nausea and diarrhea symptoms. For chlamydia, macrolides like azithromycin are no longer the first-line treatment given issues with resistance. So doxycycline is the mainstay of therapy now. And then several days later, the test results for Casey comes back. He has negative syphilis screen, negative HIV test. He's not protected against hepatitis A. He has not had protection nor previous hepatitis B, and his hep C antibody was non-reactive. From his 3-point testing, it was noted that he was detected for gonorrhea in the pharynx and the urine, and negative for chlamydia. So great that you gave him treatment on the day that he obtained these tests, because then he doesn't have to come back to clinic. Then I would at this point call the patient and ask them to stop taking the doxycycline because they didn't have chlamydia. So they don't need to finish up that course of antibiotics. And then the next topic I want to talk about is expedited partner therapy, providing antibiotics for people, partners of people who have positive STI testing. Every clinic handles EPT in a different way, so it would be great to talk with your attendings and clinic managers about how your clinic provides expedited partner therapy. So continuing on to the next case, Casey returns 2 weeks later. His discharge has improved, but he continues to have dysuria and a dull ache in his scrotum, and he has not had sex in the 2 weeks since treatment. So which tests would you recommend for Casey's persistent symptoms today? And, what are you concerned about? And this is a harder question, and I just wanted to really kind of like gauge what the room thinks about whenever there's concern for persistent symptoms.
Lots of epididymitis question mark.
Great questions. So at this point, like with a dull ache in the scrotum, could this be epididymitis? Is this a complicated UTI? Get a UA, gonorrhea, chlamydia testing again. full exam. I think these are great ideas, and those are the same thoughts that I would have too. Like, we're thinking about, could the infection have kind of involved more proximal structures like the epididymis? Could there be a treatment failure due to the ceftriaxone not covering the gonorrhea properly? Could there be, meaning resistance? And then could there be an organism that we didn't detect initially, that we didn't cover with our antibiotics, and now it's causing persistent symptoms? Or lastly, if the patient had re-exposure somehow. So those are all things that I think about and agree with the workup that the team has proposed. So in this case, in addition to the pharyngeal test of cure, you would also ideally obtain a retesting of gonorrhea and chlamydia with the NAAT. At this point, I would also recommend obtaining a Trichomonas screening as well. Trichomonas, not always, it's a rare cause of urethritis in people with penises. And however, if a patient has persistent symptoms, it might be great to screen for it. And then lastly, at this point, also recommended to get a Mycoplasma detection test of the urine. It's a shotgun PCR detecting any sorts of Mycoplasma. And this case was actually based on a real clinical scenario that I encountered. And the patient had Mycoplasma Genitalium detected. So just talking a little bit about the treatment paradigm for MGen, or Mycoplasma genitalium. It's a typical cause of urethritis, and there's been evolving macrolide resistance in the samples. Most labs in the USA don't test for macrolide resistance. In fact, it's just a PCR test. It's not a culture or anything. So oftentimes, it's best to treat with the fluoroquinolone instead. So the CDC guideline recommends first treating with doxycycline 100 milligrams twice daily for 7 days, and then sequentially moving on to moxifloxacin 400 daily for 7 days. And the reasoning behind the CDC's treatment recommendation for sequential treatment, it's because they said that doxycycline can help reduce the organism load and facilitate the organism's clearance, and then moxifloxacin then finishes the job. And that's why in MGen, it's treated sequentially. So you go ahead and call Casey and with the results, and then prescribe these medications to him, to his local pharmacy. And then he returns 2 weeks later and his symptoms have resolved. Before we move on to talk about prevention, any questions for the group? Okay, so he wants to ask you about how he can reduce the risk of contracting an STI in the future, and what approaches that you would approaches you would counsel him on. Just wanted to talk a little bit about STI prevention. It really starts with condom use, and then giving patients vaccines that can prevent STIs, including vaccination for HPV, hepatitis A and B, and MPox. And then suggesting and bringing up the topic of PrEP for patients, PrEP for HIV. And then a topic on the horizon is DoxyPEP. So Gardasil 9, many of us have prescribed Gardasil in the clinic before. It's 3 doses, month 0, 2, and 6. And then it's recommended for everyone who's age 26 or less, and FDA approved for everyone from 27 to 45 as well, but it's more of a shared decision making. The vaccine works best if a patient has never been exposed to HPV, and that means never had sexual intercourse. So for people in the age 27 to 45 age group, it's important to have some shared decision making about the benefits of the vaccine. It's a 3-dose series. I mean, so for people who are at the highest risk, you might consider still vaccinating if their insurance covers. Gardasil 9 protects against strains 16 and 18, which accounts for greater than 2/3 of all cervical cancer, as well as targeting type 6 and type 11, which causes greater than 90% of all genital warts. So Gardasil 9 is a very effective vaccination. For hepatitis A, 2 doses 6 months apart with Havrix. For hepatitis B, there's 3 vaccines that UW Medicine provides for vaccination, and I just wanted to really quickly touch upon the differences between each. There's the Hepatitis B vaccine. It's 2 doses 1 month apart. Then Engerix, which is 3 doses, day 0, month 1, and month 6. And then Twinrix, which follows the same schedule as Engerix, but it also includes the hepatitis A vaccine for people who do not have immunity for both Hep A and Hep B. In clinical practice, some of the things I really wanted to kind of talk about with the patient, with the group, is talking about that Hepatitis B has higher immunogenicity than Engerix. So for some people who had received the whole series of Engerix and still do not have immunity, if they had tested for it, at that point would be recommended to vaccinate with Hepatitis instead, which likely can produce immunity. Another consideration is if a patient is at really high risk for contracting hepatitis B. For example, patients who have multiple sex partners or who practices transactional sex. In that case, oftentimes hepatitis B immunity is desired sooner rather than later, and that vaccinating with hepatitis B is preferable to Engerix. In my past clinical experience, if I had a patient who is not immune to Hep A or B, and due to high risk, I felt that it was better to just not even give Twinrix and give Hepatitis B to obtain that Hep B immunity first, and then take time with Hep A later. I think that hepatitis B is a chronic condition with quite a bit of morbidity, so it's important to have patients getting vaccinated and getting protected earlier. And then Jynneos for MPox. This is 2 doses given 4 weeks apart. It's given intradermally. You want to counsel the patients on skin swelling. If the vaccine is given intradermally, it can create a large wheal that's itchy and red and hot, and icing it helps. Jynneos is currently prioritized for people, for men and transgender individuals who have sex with men and transgender individuals, anyone who practices transactional sex, and anyone who has skin-to-skin contact with someone with MPox. Now that we finished talking about the vaccines for preventing STIs, the next part is talking about prevention of HIV. PrEP is a really effective way for HIV prevention and should be recommended to everybody who has been tested positive for a bacterial STI. Also, anyone who asks for PrEP should ideally be counseled and given a prescription about PrEP too. PrEP exists in 3 formulations. Truvada and Descovy are oral regimen. It's 1 tablet once daily. And then cabotegravir or Apretude is given as an injection every 2 months in the clinic. The best choice really is Truvada. There's a generic available. It's more cost effective and should be counseled with patients about it. I previously gave an academic half-day talk on HIV PrEP, and I believe now it's uploaded to the YouTube portal. And if people have an interest in learning more about PrEP, can use the QR code to watch the video. And then now I want to just talk about a couple of things that are on the horizon for STI prevention in the future. And the first is DoxyPEP, post-exposure prophylaxis. This is really not in prime time yet, and CDC hasn't given full guidance. Not something that I would recommend doing routinely in clinic yet, but something good to know about in case your patients ask you in clinic. It's 200 milligrams of doxycycline, ideally taken within 24 hours, but up to 72 hours of sex, and no more than 200 milligrams every 24 hours. In studies with MSM and transgender women populations, demonstrated some efficacy in reducing risk of chlamydia and syphilis, but not for gonorrhea. So we're gonna wait for more CDC guidance before fully implementing this in clinical practice. Another next exciting new thing on the horizon is using the meningococcal B vaccine, Bexsero, for Neisseria gonorrhea prevention. So Bexsero was first created or invented for prevention of Neisseria meningitis. However, there's been some thought about using it for another organism in the same family, or genus, Neisseria gonorrhoeae. There's been a couple of observational and cohort studies about the efficacy of this. This is still quite far on the horizon, and a randomized control trial is in place and due for results in 2024 and 2025. And this, like, we'll see what it shows. It would be very exciting to be able to prevent gonorrhea with vaccination, and we'll just see. I see a couple of comments. So John has mentioned about risk for resistance to doxycycline for post-exposure prophylaxis. Yes, correct. So the CDC is gathering data for DoxyPEP as contributing resistance for organisms, and more data is still pending on that. Okay, any questions before we go on to the last case? All right, so case 3, we have Cindy. She's a 58-year-old woman, G0, who has diabetes and 2 weeks of dysuria, discharge pruritus, and dyspareunia. She recently finished antibiotics for a tooth infection. For her gynecological history, she's sexually active with 1 new male partner. She sometimes uses condoms, no past STIs that she knows of. She no longer has periods. She doesn't have any abnormal uterine bleeding. She doesn't use contraception. She doesn't have any new soaps for pelvic hygiene. You perform a point-of-care UA dipstick in clinic, and it's negative for white cells, leukosterase, nitrites, and bacteria. So what is your differential diagnosis of vaginitis in this case? And the case is meant to be vague and broad, and so there's no wrong answers or anything. So whatever people can think about. Awesome. So consideration of UTI, and then gonorrhea, chlamydia, trichomonas, candidiasis, bacterial vaginosis, trichomonas, atrophic vaginitis, candidiasis, DIV. Oh, Sarah, what does DIV stand for? Yeast infection, all the other infections.
DIV is just a squamative inflammatory vaginitis. It's a pretty rare thing.
Okay, yeah, that's great to also keep on the differential too. Really agree with the group's thinking. And we're thinking about infectious conditions. We're thinking about non-infectious conditions. And I really wanted to just kind of like dive into these buckets a little bit more. So the thoughts that we are thinking about is, could this be an STI? Could this be a non-STI infection? Is this a non-infectious etiology? So for the STIs, we thought about was trichomonas, gonorrhea, chlamydia, and also HSV can cause many of these symptoms. For non-STI infections, bacterial vaginosis, classically caused by Gonorrhoeae and Prevotella, and also candidiasis, given her recent antibiotic use. Given that the patient's postmenopausal vaginal atrophy is a point of concern, also on the differential would be lichen sclerosis, lichen planus, vulvar intraepithelial malignancies, all to think about. What is the next best step in this case then? People can just shout it out or type it. Pelvic exam. Okay, great. So the approach to vaginitis starts with the pelvic exam and wet mount. And gonorrhea, chlamydia, trichomonas, vaginal swab. If ulcerations are observed, then you would also obtain an HSV swab during the pelvic exam. If the patient has risk factors, you would do blood tests for syphilis and HIV. And then based on the wet mount results, you can empirically treat for BV, Candida, or Trich on the same day. And same day treatment is ideal if wet mount is conclusive. And back to the case. So for pelvic exam, the patient had an normal external exam. There was milky yellow discharge observed, but no vaginal atrophy. There were spots of erythema on the cervix, and the bimanual exam had mild cervical motion tenderness. You obtained the gonorrhea, chlamydia, trich swab. You didn't see an ulcer, so you didn't obtain the HSV swab. And then the patient also got blood tests for syphilis and HIV. The next part is talking about the wet mount. You would test the pH of the discharge with the pH paper if available at your clinic, and then prepare 2 slides. The first slide with normal saline and the other with KOH or potassium hydroxide. The normal saline is intended to float the trichomonas up into the slide and help observe it. And then the KOH is to help observe the budding yeast and hyphae. The whiff test, you oftentimes can just smell it upon adding the KOH onto the sample. This is the result for the patient in this case. What are people concerned about here? This can show up on a board question. I feel like I can just see mix up and you're like, boom, here's an image. What do you want to do? All right, so we have some concerns about BB and some concerns about Trich as well. So what this is, I just wanted to bring the group up, is that this cell we see right here, if we look at one of their cousins, it has a flagellum. Take a look at another one of the cousins, it has a flagellum. So this is actually a trichomonid, and I would be concerned for trichomoniasis in this case. Other things to be thinking about, the team also thought about whether this could be a clue cell, whether these could be clue cells. And I just wanted to show another image. So clue cells, we see a well-defined border and then little spicules around that defined border. And also here, a defined border and then spicules. These are clue cells. I wouldn't call this a clue cell because it doesn't have that defined border morphology, and it might just be a smushed epithelial cell. In order to diagnose bacterial vaginosis, you need clue cells that represent at least 20% of all the epithelial cells on the wet mount. And then the left image is for BV, the middle image is for Trichomonas, and then the right image is for Candida. In the middle image, we see these multiple trichomonids just swimming around, and you see their little flagellum. And then for Candida, oftentimes you see budding yeast, as in the case here, and sometimes you see hyphae too, which are like little strings. And pH can help narrow down the differential, but it's never enough to make the differential on its own. And for the whiff test, for BV, it's oftentimes positive. For Trichomonas, it's sometimes positive. So it's never enough to make a diagnosis on its own as well. We talked about the sensitivities of using a wet mount in this case, and I just wanted to bring up the fact that the wet mount itself is not very sensitive in general. For trichomoniasis, it's really only 50 to 60% sensitive, and that's why you still need to do the Trichomonas swab. And then for BV, agree with Sarah's point, also obtaining a yeast culture, because oftentimes it can catch more than what a wet mount can do. And yeah, so that's the point about wet mounts. Now, lastly, to finish up the case, talking about Trichomonas treatment in clinic, So what the CDC recommends currently for women is Flagyl, metronidazole, 500 milligrams twice daily for 7 days. For men, if they have urethritis because of it, it would be metronidazole 2 grams once. An alternative regimen exists for both women and men, and it's tinidazole 2 grams orally once. So really talking about the treatment for trich, the reason why tinidazole is listed as an alternative regimen is because it's more expensive and not all pharmacies carry it. But in reality, the efficacy is actually better for tinidazole than for Flagyl. Higher rates of cure. Tinidazole also has a longer duration of action. So given as a 2 gram dose, it can last longer in the bloodstream and the tissues with better efficacy. Tinidazole also has less GI distress. So what I've been doing is I've been, for people who can use tinidazole, you can send a prescription for tinidazole to clinic, and then to the pharmacy, and then on the note to pharmacy, if they don't carry tinidazole, you can say give Flagyl 500 milligrams PO BID for 7 days instead if tinidazole is not available at the pharmacy. And the results for our patient came back. The Trichomonas NAAT was detected. You already gave her the treatment, and you can give her a call for the results. And she was also tested negative for gonorrhea, chlamydia, syphilis, and HIV. And that's the end of the case. Any questions about the case?
Devin, there's a question in the chat from Tony about why Flagyl is one-time dosing for men.
Yeah, that's a really good question for the difference between the BID dosing for women and then the one-time dosing for men. I believe that for women, the Flagyl 500 BID dosing is to achieve a more consistent level of drug in the vaginal mucosa. For men, I think with urethritis, it might be a different kind of like PK kind of issue. I don't know the exact answer, but that's where I'm kind of guessing the difference is between. I actually don't know exactly why, but that's where I'm kind of guessing. All right. Now, lastly, I just wanted to give people a list of King County testing sites. So it's just www.kingcounty.gov/STD testing. And what you see on that website is a list of multiple community centers. This is not the whole website. This is just a screenshot of the first 4. Gives you hours, and then which sites have Spanish interpretation available. And many patients who come to see you in clinic would probably be tested and treated in clinic with you, but this would be a great resource for the partners of the patients that you see. And wanted to conclude with some shiny pearls for our group today. So the gems for today: prevention of STI includes vaccinations for Gardasil, Hep A, Hep B, MPox if the patient has risk factors. Prevention also includes condom use and HIV PrEP. Screening for STIs depend on the clinic population and the individual risk factors of the patient, and you would want to err on the side of aggressive screening for the highest yield. If a patient has a new partner, then screen for gonorrhea, chlamydia, syphilis, HIV, and if they have receptive vaginal sex, then trichomonas. Provide same-day empiric treatment for urethritis with ceftriaxone to cover gonorrhea and doxycycline to cover chlamydia. And then lastly, the diagnosis of vaginitis starts with a pelvic exam and wet mount. All right. I hope that this was a great and interesting, hopefully, way to learn about STIs. If you wanted to learn more about STIs, there's a couple of other opportunities. There's the ID ambulatory elective, where people spend a day in the sexual health clinic. In the HIV medicine elective, in Madison Clinic, we also have oftentimes diagnosis and treatment of STIs. And then some online learning would be the National STD Curriculum, www.std.uw.edu. And then the STI treatment guidelines from the CDC is also published online as well. So you can use it as a resource. They even have a mobile app if you want to, get some quick recommendations on the fly in clinic. Thank you, everyone. I'm looking for feedbacks for ways to improve the talk. Please feel free to let me know either through email or also on the academic half-day survey forms, how any additional points that you would recommend for the talk. And any questions before I stop my screen share? Oh, thank you all.
Thanks, Devin. I was looking back in the chat and I don't know if we touched on John's question / comment about any sort of like risks for resistance to about DoxyPEP. Any sort of like published stuff that you came across on like potential like resistance to doxycycline when used for prophylaxis, or is that something that's been studied?
I believe that the CDC is still studying it. I have not personally heard of conclusive evidence about leading to resistance with doxycycline yet. And we'll stay tuned. If any others in the group knows about that, I would, be glad to learn as well. All right, thank you all for having me for the talk today. Hope you all liked it.
That was awesome.